Good afternoon. I'm going to speak about diagnostic and therapeutic management of coagulation abnormalities in critically ill patients. And as you will hear from my talk, this is a very common abnormality, laboratory abnormality. Many studies show that a lot of patients in critical conditions do have abnormalities either in platelet count or in prothrombin time or other routinely measured coagulation parameters. That's also shown on this slide. This is intensive care unit patients, subdivided in patients who are on the medical ward or the surgical ward, neurosurgical or cardiosurgical ward. And if you define coagulopathy with very rough measures, with the platelets less than 100,000 or a prothrombin time that is prolonged more than 5 seconds, then you'll find that, for example, in the medical ward, but also in the surgical ward, a substantial number of these patients do have these abnormalities. We often see this. The point is that they are often taken for granted. We have accepted that patients on the intensive care unit do have low platelet counts and sometimes do have a prolonged prothrombin time. But the most important message from this talk is that you never should take this for granted, because one, in the first place, it may be an indicator of an underlying disease that needs specific treatment that is different from the treatment that you give to the patient at a certain point in time. And secondly, there is also quite some relevance here, sometimes in these abnormalities. And they are not EP phenomena, but they do have something to tell you, and sometimes they may even predict outcome. For example, thrombocytopenia. This slide shows you the incidence of severe thrombocytopenia in patients on the intensive care unit. And what you see here is that a platelet count of, let's say, less than 100 is not very uncommon in patients on the intensive care unit. And lower platelet counts also occur, although they are a little bit less frequent. But there seems to be an inverse correlation with survival. So the lower the platelets, the higher the risk of dying when on the intensive care unit. Well, intuitively, we think that this may be due to the fact that patients with a low platelet count may have a higher risk of bleeding, and these patients may experience major bleeding complications and therefore have a higher risk of dying. But this is only partly true, and only in those patients with very, very low platelet counts. They have a higher risk of fatal bleeding. But the major part of the patients who have an impaired survival associated with the low platelet count actually do not die of bleeding. So in these cases, thrombocytopenia is probably an indicator of something else, but a very strong predictor of a bad outcome. Mortality is only partly dependent on bleeding, but over the board, platelet count is a very, very strong independent predictor of mortality. And in the intensive care unit, we often calculate scores like Apache scores and other scores, but actually it's been shown over and over again that just measuring platelets is a much stronger and, of course, much more simple exercise to predict outcome in patients that are critically ill. If one looks systematically, and we did this in a consecutive very large number of patients with abnormal coagulation in the ICU, and again, abnormal coagulation was defined as a platelet count of less than 100,000 and a prothrombin time that was only slightly prolonged, there is actually a myriad of diagnoses that one could make. In our sample, but this can very much depend on the specific setting that you're working, in our sample, the majority of patients had sepsis with or without DIC. But there were also a lot of other diagnoses that actually were found in patients on the intensive care unit. And again, these diagnoses may require very different therapeutic approaches. If we start with sepsis, and you look in most of the textbooks on critical care, infectious disease, or internal medicine, you'll find that thrombocytopenia is common in patients with sepsis, and you probably will have the same idea. And if you then read in the textbooks, they usually say that this is because there is bone marrow depression in sepsis. Well, as I'm going to show you, there is no bone marrow depression in sepsis, not at all. If you want to see active bone marrow, you just sample bone marrow from patients with sepsis, and you find a high turnover of precursor cells of all lineages in the bone marrow. And there is no bone marrow depression in sepsis, which would also be very strange because most of the pro-inflammatory cytokines that are sky high in patients with sepsis also have a very positive effect on cell development and growth in the bone marrow. People more and more realize that there is actually a very high platelet production in patients with sepsis, but that platelet survival is very low. One can use the measurement of thrombopoietin in plasma as a measure of thrombin platelet turnover, and if one measures platelet survival directly with platelet survival studies, it's clear that in patients with sepsis the survival is shorter. Why is the survival of platelets shorter in patients with sepsis? Interestingly, a phenomenon that is often overlooked occurs in many patients with inflammatory conditions, but notably also in patients with sepsis, and it's called hematophagocytosis. This is a very active phagocytosis of platelets, but also of megakaryocytes in the bone marrow. And it is very common. It can be seen in more than 50% of patients who are critically ill in the ICU, and in the subset of patients with sepsis it occurs in up to 80%. And it's just a very massive phagocytosis of blood cells by activated histiocytes. It's not only platelets, it's also white cells and to a lesser extent also red cells. And also this is mediated by pro-inflammatory cytokines, mostly by GM-CSF. Well, and of course there is also consumption of platelets that determine platelet survival. I think in almost every patient or individual with some degree of coagulation of inflammation, there is some degree of coagulopathy, some degree of coagulation activation. And if one looks with highly sensitive molecular markers for coagulation activation, you'll find increased levels in virtually all patients with inflammatory conditions. If it's sufficiently severe, we're going to see laboratory abnormalities in our routine or less routine coagulation tests. And in its most severe form, we speak about disseminated intravascular coagulation. Actually, what we see in our laboratories is the tip of the iceberg. There's much more under the surface going on in these patients, and this may contribute to organ dysfunction, to outcome, and even mortality. In frank disseminated intravascular coagulation, we've learned that several pathways play an important role. Coagulation activation is actually initiated by tissue factor-mediated thrombin generation. There is upregulation of tissue factor on leukocytes, mostly mononuclear cells, and this expression of tissue factor leads to the generation of thrombin. There may also be upregulation of tissue factor on activated or perturbed endothelial cells, although this is still a matter of debate. Well, after this initiation of coagulation activation due to tissue factor, due to thromboplastin, there is also a sustained activation of coagulation due to dysfunctional anticoagulant mechanisms. Levels of physiological anticoagulant mechanisms like antithrombin or the activated protein C pathway are impaired due to impaired synthesis, impaired liver function that very often occurred in these patients, due to the action of inflammatory cytokines that downregulate these systems, for example, downregulation of thrombomodulin that is required to activate protein C, and also by active proteolytic degradation of these factors by elastase that comes from activated leukocytes. The combination of tissue factor-enhanced thrombin generation and depression of anticoagulant mechanisms results in fibrin formation. And then there is inadequate fibrin removal due to the fact that the endogenous fibrinolytic system is completely inhibited due to very high levels of its main inhibitor, which is plasminogen activator inhibitor type 1. And this altogether leads to this fibrin deposition, not a very complex scheme actually. Clinically, what we see is that this systemic activation of coagulation may lead to intravascular fibrin deposition and organ failure. And of course, there are many other mechanisms that lead to organ failure in patients with sepsis. You only have to think of insufficient circulation or metabolic processes, but also deposition of fibrin in the microvasculature may play a role. But at the same time, this continuous and ongoing activation of coagulation leads to consumption of platelets and consumption of coagulation factors, and that's what we see in the lab, and that's what we see in our patients, because sometimes they may present with very serious bleeding. If we think about the diagnosis of DIC, something strange is going on, because what we want to detect, of course, is the systemic activation of coagulation. But we cannot do so in a routine setting in most of our laboratories 24 hours a day, 7 days a week. So what do? We actually measure the secondary consumption of platelets and coagulation factors as a measure of DIC. That's not very precise, but on the other hand, we've learned to work with it, and there are now quite easy to work with scoring systems to make a diagnosis of DIC. For example, by counting the platelets, by measuring D-dimer, which is in most hospitals readily available in routine laboratories, by measuring prothrombin time, and by measuring fibrinogen. And if you use a scoring template like this, and the score is higher than 5, a diagnosis of DIC may be made. The scoring system was actually devised now more than 10 years ago based on retrospective databases of patients with critically illness and DIC, not only sepsis but also other diagnoses. And in the meantime has been prospectively validated. And this is just an example of the prospective validation of the DIC scoring system. The gold standard here, which is actually more a silver standard than a gold standard, consisted of a combination of sophisticated lab tests and clinical information. But if you would use that, then the sensitivity and the specificity of the score for DIC were not that bad. Both were more than 95%. As you can see also on this slide, about 30% of critically ill patients classified for having DIC in this sample, and this is very similar in most of the studies that have been published so far. Actually, there is also a very strong correlation, like the platelet count, as I showed you before, between the occurrence of DIC, according to this scoring paradigm, and mortality. In this slide, I show you 28-day mortality, and you see the relationship with increasing DIC points from this not too complicated scoring system. Well, let's move to other causes of thrombocytopenia in the ICU. And in about a very low percentage of patients, there may be a very different reason for thrombocytopenia. And this is thrombotic microangiopathy. And this is a very important diagnosis to make because the treatment, this is a life-threatening condition. The diagnosis is made often very, very late, and there is specific treatment and specific diagnosis that may alter the clinical course of the patient dramatically. So when do you have to think about thrombotic microangiopathy? Well, in the first place, there needs to be thrombocytopenia, but this was the starter for our differential diagnosis anyway. There should be signs of intravascular hemolysis, high LDH, a decreasing hemoglobin level, low haptoglobin, and very typically fever, kidney failure, and neurological abnormalities. And then the diagnosis can be readily made just by looking at the red blood cell film, in which you see a lot of schistocytes, which are just broken down red blood cells. And there is actually a myriad of clinical conditions leading to this thrombotic microangiopathy. But now it gets a little bit complex, because why would a thrombotic microangiopathy occur? Well, it's all a matter of increased platelet vessel wall interaction, leading to microthrombosis, red blood cell mechanically hemolyzing because they cannot pass through the microvasculature, and organ failure because there is insufficient circulation. But why is there increased platelet vessel wall interaction? Well, this is probably due to the fact that there is circulating ultra-large von Willebrand factor multimers. You have to realize that von Willebrand factor comes from endothelial cells as very, very large multimers. And these are very, very sticky proteins, facilitating the adhesion of platelets to the vessel wall. And why do we, as we sit here, do not have thrombotic microangiopathy? Because we have an enzyme. It's called ADAMTS13, and it cleaves ultra-large von Willebrand factor the minute it comes out of the endothelium. And the classical form of thrombotic microangiopathy is that you have a deficiency of NMTS13. So there is no cleavage of the ultra-large von Willebrand factor multimers, and there is much more platelet-vessel wall interaction. But this is a rare disease. It's often an autoimmune disease in which there is an autoantibody against your own NMTS13. But also more or less classical forms of thrombotic microangiopathy may occur. Hemolytic uremic syndrome, which is typically occurring in pediatric patients but may also occur in adult patients, is due to the fact that there is endothelial damage due to verotoxins, for example by contaminated meat, and these verotoxins may cause endothelial damage and thereby a massive release of ultra-large von Willebrand factor and just an overpowering of the endogenous NMTS13 or consumption of NMTS13. But also in cases of malignant hypertension, there may be damage to the endothelium and also thrombotic microangiopathy. And interestingly, but also quite complex, in sepsis, there may be endothelial damage and thereby secondary low levels of NMTS13. And this has actually been shown in a number of clinical studies, and I'm just going to show you one or two examples, in which it was clearly shown that in patients with critical illness and sepsis, levels of NMTS13 were low, and there was much more ultra-large von Willebrand factor in the plasma of these patients. We can now measure cleavage of von Willebrand factor, and if you do this in patients with severe sepsis, you'll find that they do have relatively low levels of cleaved von Willebrand factor. And actually, if you measure NMTS13 plasma levels, which is not very complex, this is interestingly related to survival in critically ill patients on the ICU. A sustained depression of NMTS13 levels had a much lower survival rate than in patients in which the low level of NMTS13 actually went up after a couple of days. Well, another and much more frequently occurring cause of thrombocytopenia in the ICU is heparin-induced thrombocytopenia. And this is a slide showing you the platelet count in patients receiving heparin. And this is unfractionated heparin, but it's not that different from low molecular weight heparin, although the incidence of HIT is lower there. What many people know is that if you give heparin to patients and you look very, very precisely to the platelet count, there is a dip in platelet count a few days after the initiation of heparin. But it's clinically probably not relevant. It's only a mild dip, and it goes away after a few days. But in some patients, there is a much more severe dip in platelet count, and severe thrombocytopenia may occur. Typically, in a heparin-naive patients, in other words, a patient that did not receive heparin recently, this occurs 7 to 10 days after the start of heparin in these patients. And these patients develop severe thrombocytopenia, but do not, as one would expect, be at risk for bleeding. Instead, their risk is arterial and venous thromboembolism. And as you can see, this risk is extremely high if the diagnosis, if the diagnosis is not made and if the patient is left untreated. It's up to 80 to 90% of these patients will have serious venous thromboembolic or arterial thromboembolic complications. So the typical combination of a patient who receives heparin, preferably therapeutic dose, unfractionated heparin, and will then present with a low platelet count and or a thromboembolic complication should be an indicator of the diagnosis of heparin-induced thrombocytopenia. And then the diagnosis can readily be made by an ELISA, an heparin-induced thrombocytopenia ELISA, which is unfortunately extremely sensitive but not very specific, which means you will have a lot of false positive patients, but on the other hand, the disease is sufficiently severe to allow for a little bit of overdiagnosis. The management is not that complex. One should immediately stop heparin and start an alternative anticoagulant, preferably not vitamin K antagonist in the early phase, but another directly acting anticoagulant, and it depends a little bit on the country where you live and the specific setting that you work in, which one should be preferred. Well, lastly, another cause of abnormal coagulation in the ICU, of course, is secondary to massive bleeding, which is the subject of the previous two talks, and transfusion. And this also may occur in a lot of situations. In the civilian setting, of course, trauma is the most important reason here. And the paradigm has become a little bit more complex than it was in the past, and this has already been clearly demonstrated in the previous talks. But to keep things simple, it starts with severe bleeding and an insufficiently compensating loss of platelets and clotting factors. And then, of course, the addition of acidosis and hypothermia make things worse. And it has already been mentioned, but it's important to emphasize, if you run the laboratory tests, it doesn't matter whether it's point-of-care tests or routine laboratory tests, we normally correct for acidosis and hypothermia because we reworm the sample and we add buffer, so acidosis will go away. So the in vivo situation in the patient may be much worse than what you see if you see the laboratory results of these patients. For this talk, I'd like to focus also a little bit on plasma expanders that are very often used in these patients, and that may at least theoretically lead to plasma dilution and an insufficiently, in addition to the loss of the platelets and the clotting factors. So it may make coagulation worse, but it's even worse. It's not only plasma dilution, but there is also often a direct effect of plasma expanders on the coagulation system. We do have different plasma expanders. I think most people will not use dextrans anymore, although in some parts of the world it's very common. Most of us use gelatin-based solutions or HES-type plasma expander use. Well, just a few words about dextrans. Dextrans induce a severe decrease in von Willebrand factor and associated factor VIII, so you will have an idea that this will make coagulation worse than it was, and especially if you use more than half a liter of dextrans, this effect is already detectable in blood. But gelatins are much more popular, at least in Europe, and they also have an interesting but sometimes also important effect on coagulation. That's very nicely illustrated by this study, a very simple study in which the authors performed scanning electron microscopy of clotting blood, and this is blood diluted with saline, 66% diluted. And they did the same experiment with 66% diluted blood with Hemocell or gelafuscin. And you can easily see from this picture that there is much less fibrin formation, much less fibrin strands cross-linking, and much less clot formation. Why is this occurring? Well, if you do a simple experiment, and this is what we did a couple of years ago in healthy volunteers, so this is patients, healthy young people with a normal coagulation system, and you give them 1 liter of gelatin-based plasma expander or 1 liter of saline, and you look at bleeding time and platelet aggregation and thrombin generation tests, you'll see a major difference between those two. And this is actually due to the fact that there is less thrombin generation and there is much less binding of collagen to the vessel wall, which is important for platelet adhesion and subsequent platelet aggregation. So you need to realize that given more than 1 liter plasma expander will also compromise even a normal coagulation system, and this may be worse in patients who have just experienced severe trauma or blood loss. So most of the protocols and the guidelines nowadays do advocate the role of plasma expanders, but still warn a little bit for too large volumes, and in that case it's much better to early change to real plasma or plasma replacements or red blood cells. So if we think about management of bleeding, coagulation disorders frequently occur in the ICU, but they need not to be taken for granted and deserve a proper differential diagnosis and diagnostic workup. We need specific diagnosis for each and every thrombocytopenia, because in some cases it will lead to specific diagnostic tests and strategies and adequate supportive treatment. And it may be that intervention in bleeding patients, think of plasma replacement treatment, may have adverse effects and may even affect hemostasis and make things worse in patients who present with severe blood loss. Thank you for your attention.